It was about 3 weeks back with complaints of low-grade fever and myalgia for the last 4 days. Subsequently, she developed some symptoms of conjunctivitis. Following that, she developed a rash that started on her face and then subsequently spread to her arms and legs over the course of a day. She did not have any bleeding manifestations and she did not have any comorbidities. On examination, she was vitally stable. She had Koplik spots over the buccal mucosa and she had a maculopapular rash over the face, trunk, and arms. There was no lymphadenopathy and the systemic examination was normal. So our diagnosis at this point was measles in the eruptive stage, and we had admitted her in the ward for isolation. The infective period, as we know in measles, is 4 days before the rash and 4 days after the rash. So and she had just come on the day of the rash to us. So we planned to isolate her for at least 5 days. On further history, she told us she has a 9-month-old child, and the child has not been vaccinated with the MMR vaccine yet. She was planning to take the child for the vaccination next week when she developed this illness. She has been in close contact with the child throughout this time, and she has continued breastfeeding the child throughout the 4 days of fever, and subsequently after the onset of rash also, she continued breastfeeding for a day before she presented to us. The child is currently asymptomatic. The child was staying at home with his grandmother, who is also asymptomatic. There were no other household contacts. So currently we were wondering, what do we do next for the child? Do we observe and treat only if the child is symptomatic? Do we vaccinate the child urgently? Or is there any role in giving measles immunoglobulin for the child? So just briefly about the measles immunoglobulin. In newborn infants, the maternal placenta develops this neonatal receptor crystallizable fragment. That receptor develops on the placenta usually during the 3rd trimester, and that is responsible for transfer of maternal IgG antibodies through the placenta to the neonatal circulation. Since it develops in the 3rd trimester, in premature infants, the levels of maternal IgG antibodies can be reduced. Particularly for measles IgG, these levels in infants persist till approximately 6 months of age. If you look at the graph, in mothers who have sufficient levels of maternal measles IgG, in children up to 1 to 4 months, nearly 75% of the population still has detectable levels. By 5 to 7 months, it drastically drops to around less than 20% of the population. And in a minority of about 10%, it persists till about 12 months, of age. So this is the reason. So as you know, so this passive immunity in most children persists till about 6 months. Beyond 6 months, the levels of passive immunity drops. This is the reason in most Western countries, the measles vaccine, as you know, is a live attenuated vaccine. So that vaccine cannot be given while the maternal IgG antibodies are still circulating. If it does, the child will not develop an immune response. So it has to be given once the maternal antibodies sufficiently drop, which is why in most Western countries, the measles vaccine is given at around 12 months of age, the first dose, followed by a booster dose at 5 years of age. Whereas here we give the MMR vaccine at around 9 months and we give a booster dose at 15 months. Yeah, so the problem with this is the passive immunity, as we saw in the previous graph, it persists in a majority of children only till about 6 months of age. So between 6 months of age till 12 months of age, there is a window period between the passive immunity and the active immunization where children are particularly susceptible to infection with measles. Usually this is not a problem because measles, if the herd immunity is more than 92%, children are less susceptible to this. But if there is an outbreak, the guidelines actually recommend reducing the reducing the age of vaccination from 12 months to 6 months. So if there's an outbreak, you give a booster dose at 6 months, followed by routine immunization at 12 months and at 5 years of age. If a child is exposed to measles, there are two measures for post-exposure prophylaxis. One is measles vaccination. The second thing you can give is IV immunoglobulin. In unvaccinated children less than 1 year of age, once they have confirmed contact with the measles patient, if they present within 72 hours post-exposure, then then the measles vaccine is sufficient. You can vaccinate urgently. And once that is done, you follow up with routine immunization protocol at 9 months and 15 months. However, if the child presents more than 72 hours after the exposure, then you cannot give the measles vaccine. Then you need to directly give IV immunoglobulin at a dose of 400 international units. This should be followed by measles vaccination 3 months later. So this is a cohort study that was done on the efficacy of IV immunoglobulin preparation. This was about 65 infants who were exposed to a measles contact. Out of the 65, 63 received the immunoglobulin and none of them developed symptoms of measles. 2 patients did not receive it because parents refused consent, and both of them developed measles 4 days after the exposure. Again, the duration of exposure here was quite short. Both the children who were infected The exposure happened in a hospital waiting room, and one child was exposed for about 45 minutes and the other child was exposed for about 90 minutes. Just to highlight that it's highly virulent and transmissible. In immunocompromised individuals, there is no 72-hour cutoff. At whatever point they present, you give the immunoglobulin followed by measles vaccination 3 months later. So coming back to our patient, in our patient, both maternal IgG and measles viral PCR were positive, and we had isolated the mother for a period of 5 days. The child had presented us on day 5 of exposure, and measles in mother was confirmed only on day 6. There is some anecdotal evidence, not anecdotal, there is some expert opinion that if post-exposure the child is still asymptomatic after day 6, there may not be much benefit in giving immunoglobulin. Just measles vaccination is sufficient. So we had discussed this with pediatrics, and as the child was still asymptomatic, we had vaccinated urgently with the MMR vaccine. We did not give immunoglobulin in this child. And child was subsequently asymptomatic and currently well followed up for about 2 weeks. Child is asymptomatic. So learning points from this case was that post-exposure prophylaxis for unvaccinated children within 72 hours vaccinated with measles vaccine, more than 72 hours immunoglobulin followed by vaccination after 3 months. And in immunocompromised individuals, urgent need for immunoglobulin. And if there is a measles outbreak, then you lower the vaccination age to 6 months for all children, followed by subsequent boosters at 9 and 15 months.
Thank you, Andrew. Any questions from the...
Was the mother vaccinated in the childhood?
Yeah, she was.
You're talking.
And the mother actually had high IgG titers. Her IgG was well above the limit, but still her IgM and viral PCR were also positive. So it was modified measles in the mother.
So when does the IgG go up in measles infection? Like by which year of infection? I'm sure it's not related to the occupants.
No, I'm not sure. Mother had IgG, so the IgG was the first to be reported. That came positive. Then the next day, IgM and viral PCR both came the next day, both were positive. And usually, if IgG is high, they do not develop measles. But in her, even though she had high IgG titers, she developed symptoms.
How do you explain that?
Modified measles in vaccinated, in patients who are previously vaccinated and have high IgG titers, they still are susceptible to develop. It's called modified measles. Their symptoms, they're milder symptoms. They do not develop complications like pneumonia, measles pneumonia. They only have a rash and a mild fever and conjunctivitis. So,
is there any cutoff of the levels, IgG levels, to say below this? Above this, you will not have measles. Below this, you may have.
The cutoff for sufficient IgG titers is considered 300 milli international units, but that is based on. That's not based on any studies. That is only expert opinions that this is the sufficient level to prevent development of measles. If you do develop it despite a level above that, that's called modified measles.
Are we doing levels?
We're not checked that.
Any data on what's the prevalence of predicted level of measles even post immunization? Right now we are having a
measles.
number of measles. Yeah. So what should be the recommendations?
So I don't know the prevalence of the prevalence of IgG post immunization. Only thing is that natural infection with measles confers a much higher level of IgG than vaccination. Post-vaccination IgG titers are about 10 times lower than IgG titers post-infection. So that is one thing, but it's still above the threshold that should be considered protective. I'm not sure of the prevalence currently.
The mother age is?
I say 26.
There are no more questions. I'll call the next person, the foot salute by Dr. Pramod.